That is, in my opinion, very very practical issue, something that we encounter, and I certainly encounter, you folks probably to a greater extent, remembering the fact that we're all providers and we want to very competently address the issue that the patient has. We have to kind of go back to the very beginning when we were taught the features of addressing the concerns of the patient. It's always, they have a chief complaint, and then from that we try to extract the history and then conduct a physical exam and then come up with some sort of diagnosis or differential, and more so with people in general medicine as you people are. Now if you were to look at those chief complaint, history, physical, and trying to come up with an answer, I'm of the belief that the history is the most important of all. Without that, you can't do anything. The chief complaint you address, but then you have to elaborate with the history. Without the history, you can't do anything at all. I'm a strong believer of that. An example that I frequently use is if outside of the apostolate there's a brand new Tesla filled with gas, and the fellow says, if you can get in that vehicle without any help and drive to Millburn, Nebraska, that car is yours. No one could do it because they don't have any history of where Millburn, Nebraska is. It's there, out there somewhere. You couldn't get there. The same is true, I think, when you're addressing these issues with patients. You have to kind of get some appreciation of the history. Well, there's one chief complaint that is notoriously frustrating. And the patient comes in and says, I'm dizzy. It's very common. In fact, it's been written about. They say that it's an extremely common complaint beyond the age of 55. As far as you folks in primary care, certainly internal medicine, it's very, very common. And you say, oh, another dizzy patient, you say to yourself. What am I to do? And I've got an office full of patients to see, and I got someone in labor at the hospital, or they're calling me from the emergency room. And so you can fail to get a history. And you'll say, oh, dizzy patient. And you might make the statement, which has been around for many years, immediately, are you spinning or is the room spinning? There's nothing worse than that, trying to get a history with such a statement. And then you might be faced with a patient who's not a good historian. You say, what am I going to do? Well, believe it or not, years ago, and I've been at this a long time, people would come and say that I'm dizzy, and the old practicing physicians years ago would say, well, go see your ear, nose, and throat person. So we got a lot of patients back in the 60s, a lot of them would come in saying, I'm dizzy. Why? Oh, Dr. So-and-so said that I've got to come and say, you're the ear doctor and you can solve my problem. Well, we had them, there's no doubt about that. So I realized that I couldn't stray away from trying to get some kind of history, and it's very frustrating to get history from a patient because they can go on different pathways and you're lost. So I kind of devised a method to see if I could quietly narrow it down. So if someone comes in and says, I'm dizzy, I'd say, yes, we're going to try to help you, and I'm going to describe 3 categories of dizziness. And anybody in the world, whether from the North Pole, South Pole, or the middle of Africa, they'll fall into one of these 3 categories. They'll say, really? Yes. And you listen to them very carefully, and then you tell me which category you're in. And by doing that, you can narrow things down significantly, because the differential on just I'm dizziness is probably 600 or 700 entities, at least. Perfect example is whenever there's a new drug that comes out, what's the first thing they say about side effects? Dizziness. So it's very common. So the secret is to, in my opinion, to describe 3 categories of dizziness and then let them decide what category they're in. And then you can really narrow it down significantly. Otherwise, you're wandering in the wilderness and you get frustrated, and you'll do what we have seen many times. You'll get a prescription for Anavert and they're let go. And we have some of the most amazing stories about Anavert that I have seen in practice. The best one was a fellow that came in, he was as mean as sin, and he had a bottle of Anavert in his hand, and he said, I'm told to come here because I'm dizzy. And this is no exaggeration. He was about 70 years old, said he was dizzy, had a bottle of Anavert, he was mean as a cat, and his pulse was 28. And no one had picked that up in the office before. That is a true story. But he had a bottle of Anavert in his hand. Well, anyway, so my classification goes like this, and I demonstrated, I think, that this morning, so we'll have to repeat. I'll say, listen to these 3 categories, and you tell me which category you're in. And the first category is when you're in a chair, you're fine, no complaints, but if you have to walk, you have to make sure the lights are on, your glasses are on, and when you walk, you have to hold on to things, otherwise you're dizzy. And without that, you feel really disturbed as far as balance and dizziness, and you don't dare walk anywhere, any distance without support. And category number 2 is a category where, again, if you're in a chair and you're fine, if you get up to walk, you don't have to hold on, but you have periods of being lightheaded, weak, you feel sort of queasy, then it goes away. And then you might have a whole series of them in the afternoon, then the next day you may have none. It's called being lightheaded, fuzzy-headed, weak-headed, and an old expression got attached to that called faintified, which means that you might faint. And you technically could in category number 2, but generally you have enough awareness that you sit down. And you never have it to speak of if you're flat in bed sleeping. And then the third category is a category, it makes no difference if you're in bed, walking, standing, going to church, driving your car, and then you use as many words as you can to describe the mechanism of rotational disturbance. So you can, out of the blue, you turn, you spin, you tumble, you rotate, you're on a carnival ride, you're on a merry-go-round ride, and you're acutely disturbed during that period of time. It can be short, 15, 20 seconds, or it could be an hour and 15 seconds. You truly can't do much because you're in this terrible spin. If you move, it gets worse. You can break out in a sweat, turn terribly white, vomit. And then after you describe them, those categories, you say which category you're in. And sometimes people say, I'm in all 3 categories. And so you say, well, what is the dominant category? You have to isolate it down. What is the dominant one? Then they'll usually take your advice and place themselves into one category. Now, if you're in the third category, then as an ear, nose, and throat fellow, I'm concerned because they're having true rotational mechanism. And that the only thing that causes that in its pure form, without other obvious disturbances that lasts, is the vestibular part of the labyrinth. Remember, the labyrinth has 2 components, hearing and balance. Together, it's called the labyrinth. And the vestibular part of the labyrinth can cause that. That's the semicircular canals and the utricle and the saccule and all the components. If they're not in that category, I won't go anywhere near it because it's wrong. Can't go in that category. Now, if they're in that category, there are essentially only 3 entities that I would see. The most common, we demonstrated that not long ago, is positional vertigo. And they'll tell you that I'm fine, except if I drop something and look under the kitchen table, or I'm in bed and I turn, or I go to the bathroom and come back and turn, and they'll say, oh, I was acutely disturbed, but it went away. And it went away predictably, because that's the nature of positional vertigo. It's position related. There's usually a little bit of a lag. Then they have this intense disturbance, which very rarely last more than 15 seconds, not associated with anything in the other part of the labyrinth, which is the hearing. Remember, the labyrinth has balance, semicircular canals, and hearing. So they have positional phenomena, short, usually a latent period, and it fatigues out, and it's repeated depending on the position they get into. It's very common. It's the most common disturbance in that third category, which is in the, once again, the vestibular part of the labyrinth. That's truly a vestibular component in the labyrinth, which once again is hearing and balance. And well, we had that, I'm sure you've seen it, and the secret is to, they're in that category, so you know which category you have to stay in. They tell you that they had it when they got up, went to the bathroom, went back in bed and turned a certain way, and then, oh, they were disturbed. And then it went away. They went back to sleep. But it's very obvious. Some people can have it working under objects, working under a table, doing things where they really crank their head back a certain way. Sometimes they can have it when they're upright and tilt, and the phenomena is short, but it's enough where they can fall. We've had people that have had positional vertigo in a head position and have fallen and broken their hip. Because they can't, for those 15 seconds, they can't control anything. They're truly incapacitated until it stops. If they're on the floor, or they can fracture their pelvis or dislocate something. But most of the time, they're usually, when we're flat, we think of ourselves recumbent on the sofa or in bed or something. Or if we're on the floor looking underneath something, well, we're on the floor already. We're not standing up on a stool trying to get some Christmas decoration off of a high shelf or something. So positional vertigo is very common. It's always benign, never ever once been implicated to anything in the nervous system, except these otoconia. They come away from either the saccule or the utricle, and they fall into this perilymph in the inner ear. And some people have it repeatedly. They'll have it, they'll get over it, months later and years later, it'll come back to haunt them. The only phenomena that causes positional vertigo is trauma. You can hit your head strong enough to shake loose otoconia, but it takes a real good blow. You really have to hit your head. A simple whiplash won't do it. A blow on the head, either through an assault or some industrial activity where you fall from a ladder, yeah, you can have it. I use the expression of, we had a fellow that worked at Kellogg on a tripod ladder that fell, hit his head on concrete. He was an electrician. Fortunately, he didn't die. He had the most severe form of positional vertigo that I had ever seen. He must have shaken loose every imaginable otoconia in his head.
Oh my gosh.
But with time and with these positional maneuvers, it usually corrects itself. There's all sorts of positional maneuvers. I don't know if one is better than the other. We use an old-fashioned one that Gene gets out of the drawer and gives it to people, and it's generally very effective. The only thing about positional vertigo you have to remember is that if you see the patient in the office and you want to do the Dix-Hallpike maneuver, which you should do to verify it, the type of nystagmus that you occur is rotational. It's not jerky horizontal, it's rotational. I think the patient we had real dramatic rotational nystagmus. Yeah. And if you do a Dix-Hallpike and it's positive on the right, you have to sit them up and wait and do the left. It can be bilateral. And if it is, these traditional repositioning exercises don't work well. You have to use special exercises, but that's not common. But you got to check for it. Because if you only check one side, you check the right side and they have it, and you have them take the right instructions and they don't get better, it's because you didn't check the left side and they had it on both sides. No, you're not going to have them very often, but you've got to check both sides, because someone will question you, did you check the other side? And it's so easy to do it because you're in the process of doing the maneuver right then. So that is very common, very common. And sometimes the history can be a bit vague, but they've placed them in that category. They've placed themselves in that, what I call the third category. So stay there. Don't get into the other two categories.
Interesting.
And see if you can't sort it out. If they truly have rotational phenomena, where they spin, turn, tumble, and rotate, stay in that category. The second one is, of course, classic Meniere's disease, where spontaneously they become acutely vertiginous, but it doesn't go away, and it's not position related, and it lasts, and it spills over invariably into the other part of the labyrinth, which is the auditory part. So they have problems with hearing. So they have very often vestibular and auditory. So they end up with this intense vertigo that doesn't go away. They can have fullness and tinnitus, and they can really have GI disturbances, nausea and vomiting. And they are miserable. It can last an hour or two. If you move them, it gets worse. Then it'll gradually diminish and go away. Well, that history is perfect for a prolonged period of intense, true rotational vertigo. It's not positional. It's indeed involving a good component of the labyrinth, so it's Meniere's disease. And Meniere's disease is not rare, but it's not terribly common. And it is still a disturbance that seems to be related to excessive sodium intake. A meal or two that's really loaded with sodium. It can be a very good meal, properly made, perfect presentation, nothing tainted, but they enjoy something terribly salty, and it can affect the amount of fluid in that part of the inner ear called the endolymph. The endolymphatic sac can distend with sodium, and if it does, those people are violently disturbed for a period of anywhere from half an hour to 2 hours, almost always with intense nausea. The way to make that diagnosis is to just, if you're there, is to just look at their eyes, and they have this intense nystagmus, and that nystagmus is jerky. It's a jerky nystagmus rather than a rotational nystagmus. So you have someone who's sick, doesn't want to move. If you move them, they feel bad, and you look in their eyes and they have jerky nystagmus. You have the diagnosis. And here again, it is not associated with any other major neurologic disturbances. If these people go to the emergency room, they'll tell you, I was sick at home and vomiting. They put me in the car, the squad. It was worse as I was driving to the emergency room because motion really makes it worse. They get to the ER, they have a $3,000 CT scan and all kinds of tests, and no one looks at their eyes to check for nystagmus. All you'd have to do is look at their eyes, and you wouldn't have to do another test. As long as they communicate freely, they've got strength in their arms and their legs, you don't have to evaluate these people for any type of major intracranial neurologic disturbance. But that's usually what happens. And so they sit in a gurney in a room and they vomit, and they've had all these tests, and it's worse when they go and have these radiographic studies. They come back vomiting more. No one looks at their eyes. I shouldn't say that categorically, but a lot of people don't. You just look at their eyes, you can just as well stop. And Meniere's disease it's not rare. It is related in a lot of people with excessive sodium, so you have to caution these people about sodium intake. They should probably be on diuretics for a short time, and then hopefully it won't be recurrent in nature, because it can be, despite your best efforts to prevent these attacks from coming, and they may watch their sodium intake. But generally you can control them medically. You might say, well, do you give those people Antivert? No, I don't. There's no value. They'll get over the disturbance after several hours. But I think those people should be evaluated, particularly if they have any complaints referable to their hearing. Because they say, when I was sick, I had a lot of ringing and my hearing went down. Well, then you're over that now. Do you still have ringing? Yes. Well, we better just check your auditory function. Remember, vestibular, auditory. So have someone come for a hearing test to determine if they have lost some hearing, the attack is resolved, but lo and behold, you do a hearing test and you find that they have a decreased auditory function on that side. Well, they really had a major insult to cause that to happen. And with repeated insults, those people have further and further decrease in auditory function. So you have to really stay on top of those individuals because they don't like these violent attacks. They don't like to have a distorted hearing and progressive weakness in hearing. But that's not true for all of them. There are people who have a significant vestibular component, little in the way of auditory components. That's the second one. And the third one, which is considered rare, I'd say uncommon, is a condition called vestibular neuronitis. And the tip-off there is that they all of a sudden become violently dizzy. They have this intense rotational phenomena. Very seldom do they have any disturbance in the auditory part of the labyrinth. And for some reason, an hour or two goes by, they're not better. 3 hours go by, they're not better. 6 hours go by, and they're not better. You say, well, this isn't Meniere's disease or hydrops. Usually in 2 or 3 hours, they get over it. They feel like they're all washed out and they vomited, but they're over it. These people, they're not over it. 6 hours, 7 hours. And once again, all you have to do is look at their eyes, and they have nystagmus, jerky nystagmus. And it's not a very common phenomenon, but the tip-off is that it lasted so long. They were dizzy from 4 o'clock in the afternoon until 4 o'clock the next afternoon, and they had nystagmus. And so they would be considered to have vestibular neuronitis. Now, the cause of vestibular neuronitis is debatable, but most people think it's a viral insult to the labyrinth. And they'll get over it. It may take them 3 or 4 days through the initial attack, and then their ability to ambulate is impaired maybe for another month, and then finally they get over the disturbance. But they might miss 2 or 3 weeks of work. And those are the 3 entities that we would see in that third category. The other 2 categories are not otologic. They're not. So if they have disturbances in category 1 or category 2, fine, but don't get into the ear because you're not going to go anywhere. Now, if they're in category number 1, where they have to have good eye vision, lighting, and support, and they go about slowly, they have to have some disturbance within the neuromuscular integrity of osseous structures. They could have something as common as peripheral neuropathy from diabetes. They could have Parkinson's disease. They could have general senile changes of age. They just need support all the time when they're up and about. Some people can have this just from deconditioning. They've had a horrible encounter with some surgical procedure in the hospital for a long time, and finally get out after 6 weeks, and they're terribly disturbed when they're up walking about. Well, they're deconditioned, and depending on whatever the cause is, you would address that. You might say, well, what about brain tumors? Brain tumors don't fall into that category. They're so sick you won't even see them in a clinic setting, so don't worry about this. Now, I missed a brain tumor. No, you're not going to miss brain tumors if you do this reclassification, because they've been so sick neurologically they won't be coming to see you because they're dizzy, I can assure you. Because that's sometimes the worry that people have. The second category is by far the most common. If you had 100 people, the vast majority, 80% would fall in the second category. We talked about that this morning. The second category of periodically being lightheaded and fuzzy-headed and weak, it comes and goes, and then the next day they don't have it, and they have it again. They just feel fuzzy and weak. Is anything at all that affects cerebral vascular perfusion. So they have to have adequate amounts of blood, properly oxygenated with nutrition under the right pressure through vessels that are patent to your head. So it's usually a cardiovascular disturbance, or it could be associated things such as, let's say someone is terribly anemic, they'd be in the second category. Or if they have significant vascular disease in the major arteries of their neck, or they have some major cardiovascular problems such as an arrhythmia or beginning stages of congestive heart failure, they would probably be in that category. Or like the gentleman with a pulse of 88, they have a slowing of electrical activity to their heart. But in this second category, we proved that this morning, in that category are people who can have a mental health issue. Because those people are constant hyperventilators, so they always feel a little bit fuzzy and lightheaded. One day is worse than the other. And that's what we had this morning, that one gentleman. So he fell in that second category of just being periodically lightheaded and weak and not very comfortable on their feet. Then it might go away and then come back to haunt them. Or they might, as this fellow said this morning, he's obviously admitted that he was a bit anxious and apprehensive. So they would be also in that particular category. The ones that I've seen peripherally that are in that category are people that are dealing with hypertension and truly cardiovascular phenomena that would put them in that category. But at the same time, people who can be chronically dehydrated can be in that category, which is a rather large grouping of people. But then you stay in that category of what's affecting perfusion and stay out of the other categories. Don't get into the other categories because you're wasting your time there. And that's what I've found over the years to try to put things into perspective, because you'll wander with this history everywhere, and it's frustrating. It's frustrating. Yes?
I'm sorry, I just had a question. Have you ever noticed a trend with women who have been pregnant and have had an increase in dizziness or less tolerance for roller coasters or car rides after being pregnant specifically? No.
Well, once again, if they're complaining of an intolerance to motion, they're complaining of an intolerance to motion, I guess technically they could be in the third category, but those people usually have a history dating back to when they were children of motion sickness, true motion sickness, and which they gradually get over as they get older. But you're talking about someone who's pregnant and after pregnancy have that phenomena.
Yeah. I've just noticed it with some friends and myself personally too, so I was just curious if there was any.
No, I still think that is not truly in that third category. And if they said, well, I've had motion sickness just for all my life, and it seems to be a little bit worse now, and it's sort of like I had when I was a kid, then there are some people who truly have motion sickness all their life. They do. And you might say, well, what causes that? Well, their history is pretty clear cut. They say if I ride in the back of a car, I feel bad. If I can't go to any carnival rides, I just can't. I just cannot do that. Those people have a simple phenomena. Our inner ear is always sending messages to our brainstem constantly. As we get older from infancy, the brainstem, being remarkably made, develops suppressors that stop these impulses coming from our labyrinth, and they shut them off by the time we get to be late teenager or adults. There are some people who do not develop, and we don't know why, suppressors from the brainstem. They're always troubled with motion sickness, and they can be 35, they had it when they were 5, now they're 35 and 55. Now those are people who will tell you, I don't want to go on the cruise with my husband because I don't like that constant motion. You say, well, you don't have anything terribly wrong, but your brainstem has not learned to suppress these impulses that come from your labyrinth, it's not your fault. It's just that the suppressors didn't develop. Those are the people that respond to antivert, Marazine, and those, because all Marazine does is to diminish the impulses from the labyrinth to the brainstem. And that's why they're good for motion sickness. They just diminish these impulses. They also have sometimes a bit of a sedative effect too, which sometimes people like and don't like. But in answer to your question, I suspect that it might be go back to this lack of suppression in their brainstem. And if they don't have, with that, true rotational disturbances, I'd keep them out of that category. I just would.
Mhm.
Okay.
I would keep them out of that category.
Thank you.
The other, speaking of that second category, people can get into that second category who are extremely fatigued. People who don't get enough physical rest. People that work for years from 7 to 3, now they have to work from 11 to 7, and their days and nights are mixed up. They can have this sensation of being just sort of weak-headed, lightheaded, not feeling comfortable because their circadian rhythms are all disturbed. They're not getting enough physical rest. That's a common one.